We're ready to roll. Thank you for joining us today for the session on law enforcement and marginality. We have two excellent presentations today. We're going to start with Danisha Jenkins from the University of California, and her presentation. Their presentation is titled, "This is not a patient, this is property of the states, nursing ethics and the immigrant detention apparatus." The second one, led by Arthur McLaughlin, University of Toronto and St. Michael Hospital in Canada, entitled "Support for the Margins, a program evaluation of the John Howard Society of Toronto Reintegration Center." Unfortunately, Nicoleta Palisok cannot join us today, but I think we're going to have a great discussion on this important topic. Each of us is going to have 15 minutes. So Arthur, Danisha is going to start with 15 minutes, followed by Arthur, 15 another minutes, and then we're going to leave the questions and answers for the end. So make sure that you type your questions, and then we're going to have 20 solid minutes for Q&A session. Okay, so Danisha, take the floor.
Hi, everyone. Thank you so much for this opportunity today. I very much loosely kind of formulated this presentation as a discussion, but a little bit of background about me. I'm a registered nurse and currently a director of critical care and emergency services here in Southern California. My entire background is primarily in the trauma and psychiatric setting, and also some time as a nurse in juvenile detention. And a lot of my experiences as a nurse have been formulated in the intersection of law enforcement and nursing practice. I'm sure many of you remember the highly publicized arrest of the nurse who refused to draw blood on a patient when the law enforcement was requesting or demanding that she do so. That incident made public a dynamic that pretty much any nurse you speak to in an emergency setting or dealing with custody has experienced, maybe not to that degree, but it highlighted some of the dynamics that occur when you are working with patients who are in custody. So I'm presenting to you today here a paper that I published with some of my colleagues in Nursing Inquiry, and the title of the paper is "This is not a patient, this is property of state." This is property of the state, and this is nursing ethics and the immigrant detention apparatus. And the title of this paper is very important. This is not a patient, this is property of the state, because that's actually a direct quote that was said to me by a law enforcement officer when having discussion about what a patient required in their care. So this paper, in very broadly, begins with a case study in which we discussed that there was a young adult in the custody of ICE who was brought to the emergency department by federal law enforcement after suffering what was a reported traumatic injury. As with many others, this patient's wristband did not have a patient's name, but only identification numbers that are assigned by law enforcement. What the nurses found was that clinical assessment was quite inconsistent with reports from ICE agents and demonstrated that there was actually no traumatic injury that had occurred, but the patient suffered a devastating medical condition. This patient was unconscious, non-responsive, and required mechanical ventilation. And despite this, the patient remained shackled to the bed. The nursing staff did request that these shackles be removed in order to physically turn the patient, but the nurses were met with the response that the law enforcement did not have a key and the shackles could not be removed, and that the nurses would have to wait until the morning to move the patient. This patient began to exhibit seizure activity, and the nurses prepared to administer medication to stop the seizures, and the officer stated that they did not have consent for the patient to receive the medication, and that the nurses were not permitted to administer any medications until the forensic phlebotomist arrived to collect a sample. When the nurses pushed back and confronted what they perceived as an unethical delay in medical treatment, the agent replied at this point, "This is not a patient, this is property of the state." The nurses reported that they perceived that the agents really demanded to know a lot of details about the patient and reported frequently to an unknown person many details of the patient. So The detention facility also ultimately dictated that the nurses were not permitted to speak to the patient's family when it was determined that the patient was brain dead. This patient was brain dead, and the detention facility also dictated that the patient could not be removed from life support. And all communication, including information about donation of organs, was to be made by the warden at the facility. So really globally, this is a firsthand account of state-sanctioned medical intervention that was reported to nursing leadership by the nurses who in this dynamic were quite fearful, but also reported witnessing similar transactions quite frequently. And of course, this case is not globally representative of all medical interventions in this setting. However, it does offer an important occasion to reflect on really what are these power dynamics that inform life and death medical and nursing decision-making when there is a patient in custody. So from the moment this patient and many others like them arrived at the emergency department, it was made abundantly clear that in the perspective of those in their custody, this is not a patient, but property. And of significance, the person described here had not yet been convicted of any crime, nor had they stood trial. Despite that, all autonomous decision-making and attendance to the rights of the patient, including identity and personhood, especially their relation to their loved ones, had been entirely stripped for them. So in this dynamic of care versus custody between patient and property of state, it's obvious that the acceptable standards of medical and nursing care are going to come into ethical collision with these custodial paradigms and decision-making practices. And these really do not appear to operate within the spectrum of care as is normally considered from a nursing perspective. So a case study like this is at the foreground of kind of these ethical stakes that clinicians face who work in these settings, where these decisions and the delivery of acceptable standards of care cannot but be political or politicized acts. So in this paper, I delve further into the scholarship and philosophy of Michel Foucault and Giorgio Agamben, for those of you who are familiar with those philosophers, and also offer more so a theoretical account of this care versus punishment paradigm that's operating here. And this is really critical, and this audience probably I'm preaching to the choir, but it's well known that surveillance, detention, and deportation of immigrants presenting at the US border is operationalized by ICE, it's operationalized by Border Patrol. And as of 2017, ICE operated over 1,400 immigration detention centers. And this is a number that does not include Border Patrol facilities within 100 miles of the border. So while this is a prevalent issue at the border, because of the expanse of immigration and detention facilities across the country, this is a dynamic, particular with Border Patrol and ICE, that nurses and healthcare providers all across the United States of America may be faced with. We also know that the increasing rates of the US immigration detention are congruent with this pervasive mass incarceration that is happening in this country, with specific attention to the indigenous and people of color and mentally ill members of our community. We know that rates of incarceration are higher than anywhere else in the world. So this is to say that this is not necessarily a one-off ethical challenge that healthcare providers may be faced with. So caring for people who are either accused and convicted of crimes is a required duty for many nurses working within the hospital. And patients in custody, whether they're convicted of a crime or not, are increasingly receiving medical care in the hospital settings. And hospital care accounts for about 20% of prison healthcare spending. ICE spends about $260 million of its $7.6 billion detention budget on a spectrum of healthcare services, and this includes emergency visits to acute care hospitals. So for the nursing staff that are engaged in the provision of this care, very strict adherence to professional ethics can be greatly challenged by the presence of or interaction with custodial officers. And research conducted in corrections and forensic psychiatric settings have very much shown that the tensions between custody and care have a very deleterious effect on nursing practice and outcomes for patients. Representatives of law enforcement agencies, their task is to keep this patient under strict surveillance, and paradigms of this control and punishment can interfere with and really impede nursing care by restricting and altering or even arguably deforming the nurse and patient relationship. So globally, this paper is about a collision of the worlds of custody and care, and these situations in which nurses are often forced to choose between complying with the demands and constraints put in place by law enforcement officers or practice nursing according to recognized standards of ethical care. And in many cases, like the case study I presented here, nurses are unable to choose because that choice has been made for them. So kind of in conclusion, and I'll save more time for discussion on this and getting the feedback and experiences of the people joining this talk, this is an issue of biopolitical power and how nurses and law enforcement are positioned with one another and the patient in determining the potentiality and life and death of patients that are in custody. Thank you so much.
Thank you, Danisha. I think we're good. Thank you for that excellent presentation on discussing the biopolitical power and apparatus, right, impacting immigrants population and the implications for care, right, the implication for care. So I'm looking forward to that discussion and Q&A session. Arthur, take the floor.
Okay. You can see the PowerPoint?
Yep.
Okay. Yes, the title of my paper is Support from the Margins for this presentation. Support from the Margins, Client Experiences of the John Howard Society of Toronto's Reintegration Center. I'm one of a number of authors working on this piece. Flora Matheson was the PI on the study. Tara Hamann and Celia Maya Lancheros. We're all at the MAP Center for Urban Health Solutions at St. Michael's Hospital, and I'm a postdoctoral researcher working with Flora and her team across a number of projects, this being one of them. My training too, I guess I should point out, is not in public health, but it's in sociology. I'm an ethnographer, so sociology, social psychology, ethnography, crime, deviance. We can have this debate later, but sociology like subsumes all these other things anyway. Agenda. First, I'll review the problem, then the program, the Reintegration Center, the study, and then I'm going to focus on the findings, the qualitative findings in particular that we derive from this project. And then finally, in perspective and looking ahead. Okay, the problem. Research has demonstrated that there is a strong relationship between incarceration and health. And while some have argued, and it makes sense that incarceration is an opportunity to improve health outcomes, given that you have the population in one place and under control. This is not really panning out in practice. And the release period in particular, the early days of release, early days, weeks and months, few months, presents a variety of challenges with significant personal and community effects, such as high rates of morbidity, high rates of overdose, injury, and homelessness upon release. These all conspire to contribute to the cycle of incarceration that we see among this population. Inadequate discharge planning in the province of Ontario, and I know elsewhere in North America and probably across the world, also contributes to poor post-release outcomes. And upon release, there is also a lack of tailored or dedicated reentry services and supports for the population. So you have a population with a number of complex needs that are entangled and connected in one need and challenge affects another and exacerbates another. And the supports aren't there to adequately address these needs, and it contributes to cycles of continuing reincarceration and criminal justice involvement. So John Howard Society of Toronto developed the Reintegration Center as an intervention into this process, as an attempt to provide some tools or resource to help break the cycle of incarceration, support this population upon release. The John Howard Society of Toronto is a nonprofit organization committed to providing and developing programs that reduce the social, economic, and personal costs of crime. John Howard Society is dedicated to helping those who have been in conflict with the law and individuals at imminent risk for conflict with the law. The Reintegration Center is located next to, or at the time of this study, I'll get more into this in the discussion, but nearby the Toronto South Detention Center, which is one of Canada's largest incarceration facilities. Peer support workers staff the RC, and it was designed to provide clients with immediate supports upon release. So things that they could help them with as soon as they came in, such as access to clothing, food, transportation, email and phone charging, harm reduction kits, and information. And for needs that would require more extended support, the RC also referred clients to other John Howard Society services or services outside of John Howard Society within the area, the Greater Toronto area. Okay, the study. With grant funding from the Ontario Trillium Foundation, we conducted a program evaluation of the Reintegration Center using mixed methods approach. This presentation is focusing on the qualitative data, but we also gathered quantitative data as well. So clients, the way it worked, let's see if I can explain this simply. So the Toronto South Detention Center is an area of Toronto, it's almost a suburb of Toronto in Etobicoke. And upon release, you are released in a kind of in the border of a semi-industrial area and residential area, but very suburban. Most of this population that is experiencing homelessness upon release usually moves to downtown Toronto, which is about a 20 to 30 minute ride on the public transit to get there. So people are released from the Toronto South Detention Center. They often have nothing, and they're just dropped off in this industrial space without any resources, without anyone there to help them. And it could be at winter, it could be in the middle of the night or at night. And so the RC was developed to help them upon this immediate release. The findings. What is the client experience of the RC's services? Okay, so we conducted 21 in-depth interviews with RC clients. And from that analysis, 4 themes really became prominent. And those are the themes I'm going to focus on today. So providing immediate supports, making referrals, staying on track, and becoming a trusted reintegration resource. As I noted earlier, the emphasis of the RC services was on providing immediate supports, usually within the first hour of their release, minutes, hour of their release, or the first day. Most of their clients were released on that day. So And it's often the first sort of interaction these men had when they were released from custody with those outside of the institution, correctional institution. The RC's proximity to the detention center facilitated these first contacts and provided rapid, though not complex, services. Here's an example of kind of a benefit that clients saw in the center. I'd just like to thank you guys. I like this resource center. It's kind of actually one of the better ones, and it's probably because it's right next to the jail. And it's nice that you guys have a place like this right from when you're released. So I would like to thank you guys, the RC. And I'm really glad that John Howard was there the day I got out. I think it's wonderful to have a location beside the detention center, and it made a difficult day a little less difficult. I'm just glad you're around. Priority needs. So when people are released from the detention center and they first enter the RC, they would do an intake with a peer support worker. And during that intake, they were asked to identify their 3 top priority needs as they return to the community. Housing, unsurprisingly, was the most common priority among clients and the most difficult to address. And there were a cluster of other priorities that followed housing around drug treatment, clothing, transportation, employment, education, financial assistance, and relationships. The RC met some of these priorities immediately, such as clothing, tokens for food, tokens for transportation, and clients appreciated this. I'm used to going without food, and the Tim Hortons card you guys provided is helping me survive. Tim Hortons, I guess it's making its way to the East Coast there, the northeast of the US, but that's our Canadian coffee and donut shop. Providing immediate supports, moral encounters, so much more than just basic practical supports. These interactions also contributed to clients' overall sense of well-being in the first moments of reentry. The RC encounter left participants with the sense that their lives mattered and that their dignity and rights as persons were affirmed. For example, when I went in and got out and I talked to the person, she cared. It wasn't more like paperwork. It was more like, sorry to hear that. It was a human and I felt human. I didn't feel like a guy who came out of jail. I talked to her about what was going on in my day, what was going on with me, so that there's still this sense that you're a human being and I'm treated with respect, not like a child. They treated me with respect. Making referrals. When the RC could not immediately address some of these priority needs, they attempted to refer their clients to either other John Howard Society of Toronto services or beyond the John Howard Society of Toronto to other community service agencies within the Greater Toronto area. So most clients were referred or received referrals to programs, and the interviews, these qualitative interviews, were generally conducted about a month after their intake, and most reported at that time that those referrals had been helpful in meeting at least one or some of their priorities. These referrals, one theme is facilitating these connections to services. Many of the referrals, as I said, were to the broader suite of John Howard Society of Toronto services, especially the employment and housing programs of John Howard. Participants also talked about being referred to other organizations. And it's really kind of, for me as an outsider to some of the discipline, kind of revealed to me like the social components of John Howard as being a feeder program and point of entry into the network of services in the GTA, which, as with other areas, tend to be siloed, and each organization tends to operate independently without much dialogue and connection, communication across these organizations. So this model tended to mitigate against that siloing of services. For example, many clients, in addition to receiving harm reduction kits, were referred to drug treatment programs. If I didn't have this place, I'd probably be back on the streets using crack and back in drugs and jail again. You did the best you could in here, I think, getting me back into treatment centers, getting me back into society, showing me a way to get help. There were also referral challenges. People have refused referrals for a number of reasons. One example is that they didn't feel a need for them because these types of services weren't a good fit for their personality or their style of use, such as drug treatment. They gave me a couple of options. I wasn't sure I wanted to take those routes, like the counseling and shift. That's going to make me want it even more. Put me in a room full of people that are talking about the best times they had smoking dope, and it's going to make me think, hey, I'm going to smoke. The program and the peer workers, kind of their person-centered approach, that orientation respected the autonomy of clients and supported their decision-making. So there was no sense in the data that referrals to treatment centers were imposed in any way on clients. Staying on track. Of course, with interviews typically occurring 1 month after release, these were still early days and there were many challenges and barriers ahead. More work and support would be required to avoid some of the traps and patterns and places and behaviors that might bring people back into criminal justice involvement. Clients identified a number of needs, and these needs were interrelated. And the tendency in the data that I saw was that although they came to the RC, they expressed they had a number of needs, but part of the conversation with peer support workers was trying to figure out which ones were priorities, and then among the priorities, which ones would we address in kind of a stepwise fashion, so that our limited resources weren't spread too thin and we might be more successful overall in the long run. For example, securing employment may provide a stable base from which to achieve other reintegration goals. So let's work on priority 1. If I could get work, I'll be happy, I'll have money, and then I can start working on everything else. Staying on track is also related to the relationships and networks in which people are released and returned to when they re-enter the community. The RC didn't have control over this, but clients brought this up, not only in terms of the challenges that they might face, but also like asking for help with some of those that they are in and around in order to ensure their own success. So, for example, one participant in discussing his need for drug treatment hoped he could access a program that would allow his partner to attend as well, so that they could work on their substance use issues together to ensure greater odds of collective success. Okay, and this is the last theme, okay, Omar? You're not too antsy, are you? No, everything's fine. Becoming a trusted reintegration resource. Okay. The RC, again, this is my impression of the data. The RC seemed to really stand out amongst this, amongst other services, community services that in the community services that provide supports to this population. They may not be targeted to the population, but other service agencies, this population has a great deal of experience with. So given that experience, I was struck by how much they emphasized, clients emphasized that the RC stands above, and John Howard, above and beyond some of the experiences they've had across other organizations and institutions. And that was very important and meaningful in their reintegration. So for example, well, to be honest, every question that I've had, every venture I want to try, every advice that I need, it's been answered. And it's very rare for me to find a program that does that. I've used this as my backbone. This is my rock. No other agency in the last month has given me as much help as this place. I mean, the interview we had when we first got out, we sat for 2-3 hours. No other agency would give me the time of day. So part of that clients attributed to the peer support workers. Peer workers with experiences of criminal justice involvement provided a trusted resource that clients could count on to understand their struggles and offer useful strategies to overcome them based on their own experiences. So at this other organizations, I go to meet a worker and you can tell that they don't have the life experience. They're just sitting there like a deer in the headlights. They haven't walked a second to my shoes. But this is why you have, Kay. That's why I like John Howard Society of Toronto. Kay as a peer support worker at the RC. And in fact, some clients also in the data interviews revealed that not only did they trust their peer support workers, but they provided like a model, a possible self in the future that they could aspire to. That, hey, if this person with these experiences that were similar to mine did this and is working in this role, maybe I can too. Maybe there's hope for me beyond reincarceration. Back to supports enduring relationships. So the supports within the RC, and the RC being situated within John Howard, was a powerful model because you could both address immediate needs and make referrals all within basically the same organization. And that provides the consistency of source and builds trust with clients over time. It's all within, which is great. I'm the kind of person, I have severe trust issues. I don't want to be going to a different million workers and having to re-explain everything over and over and over again. I've had to do that for 10 fucking years. Similarly, another participant said that he would like to stay in contact with peer support workers because he trusted their advice and would be able to work with someone he knows, who knows him well and his case well, avoiding case explanation fatigue. I don't know if anyone's ever said this, but to be honest, just someone that I can trust to talk to if I ever needed advice, because you already know what I've been through. I've been on your caseload for a month. You know what I've gone through, because I don't want to have to re-explain my situation to worker after worker. Okay, in perspective, this is brief. The RC was well received by clients overall and cited again and again as an important tool or resource in facilitating their re-entry process. More work is needed to assess the outcomes over time of the RC, but within the short duration of the study period, the results were promising. Looking ahead, John Howard is a national organization with regions and offices in a variety of municipalities, and other regions are considering implementing this model. And the John Howard Society of Toronto is in the process of moving from a bricks and mortar reintegration center to a mobile trailer on site or right next to the site. I'm pretty sure it's in the parking lot of the detention center, so that when people are released, they're able to serve them right away. Thank you.
Thank you so much for that great presentation and highlighting the significance and importance of wraparound services for working with individuals impacted by the criminal justice system. So now we have, I believe, 12 minutes for Q&A, and we open the floor for questions. For presenters, you can unmute yourself or type the questions in the chat. Excellent. Flora, this is a question for from Flora to Danisha. Danisha, what are your ideas about changing the system's view of people's property chattel? Thought question, I know.
So I don't know if my camera's working. Everything's very delayed on my end. I apologize. This really comes from whether or not I'm answering from a real life perspective or from the perspective of my paper and the philosophical underpinnings of Foucault and Agamben. And for those of you that aren't familiar with Foucault, his idea of sovereignty and biopower is that punishment used to exist in public forum at the scaffold when people were publicly shamed, drawn and quartered, and it was a public event. However, the control of the masses was deeply inefficient in that way. And so the evolution of biopolitical force and control of power has gained great efficiency by instituting control over persons through mechanisms like schools, prisons, detention camps, and even hospitals. So through a Foucauldian lens, in this situation, the nurse is operating as a tentacle, as an arm of law enforcement to efficiently suppress and oppress those that are deemed to not have bios, to not have the political voice and identity, because it doesn't serve the sovereign power. Now, that's like a very high level philosophical perspective, but what I talk about in my paper is how important it is to speak the truth and to tell these stories, because what happens is this punishment is no longer in the panopticon. It's not in public view anymore. So those people that are witnessing these types of state oppression and control must make visible these types of experiences that are happening. So it is very important that nurses, healthcare workers, teachers, all types of people take to journals, go to presentations, write and share these experiences of the ways that control is being exerted. We also need to identify very clearly the ways in ourselves in which we are upholding this scaffold of punishment to these marginalized and very vulnerable groups of people. So the ways in which people like nurses, physicians, social workers, psychologists, teachers, counselors, how are we operating as arms of law enforcement? And in what tangible ways throughout the course of our very day can we push back against these maneuvers? How do we make it a little bit less easy for these arms of control to inflict harm on these members of our community? I don't know if that's a great answer, but that's my thoughts.
Yeah, that was excellent, Danisha, and kind of a follow-up building on that point. Can you talk a little bit more about these models of care, right? And how can we address this issue of immigration as a determinant of health? Like I'm thinking about medical legal partnerships, right? The potentials of attorneys and general counsel to intervene, right? And address some of these legal challenges that are happening within our healthcare systems. So I wonder, like strategies, can you talk about models of care that could be implemented in hospitals and clinic to address some of these challenges and this biopolitical power that is happening within hospitals and clinics and settings?
Yeah, so one thing is institutional policies are incredibly important for healthcare workers to lean upon. And Physicians for Human Rights, for those of you that are familiar with their organization, has a lot of excellent resources that help to kind of outline the ways in which healthcare workers can identify ways they're participating in things like medical deportation, for example, unknowingly, and what you can do within your organization to not participate in things like getting chest x-rays for the benefit of Border Patrol so that people can be brought to Mexico if they show evidence of tuberculosis, for example. So those are some important ways. The issues with hospitals is they have become exceedingly closed off, right? They've become corporatized. So it's very difficult to get in there for attorneys to get in there and advocate, which is why part of my dissertation is demonstrating that this point of intersection from the nurse and from law enforcement, which are two complete opposite ethical constructs, it is at this point where there's a rub that the nurse must be able to lean on policies and ethical guiding documents to push back and not allow their practice to be deformed.
Excellent. Any other questions from the audience, attendees? I do have a question for Arthur.
I knew you would, Omar.
I was wondering if you can talk a little bit more about the cost benefit of these models of care, right? Of these reentry models of care. I know that there has been a lot published, but can you talk a little bit more about, cost benefit for potential sustainability of these models and uptake of these models in other settings and in other jurisdictions?
I think thank you for the question. What I think John Howard is doing now is really dealing with that problem, or responding to that problem of sustainable funding for programs such as this. So what we evaluated was the reintegration center in a bricks and mortar storefront that was within a block or two of the detention center. But staffing that and paying rent and maintaining the lease in a city that has real estate going crazy and has been for some time was an ongoing challenge, especially with strapped financial resources, which most of these community service providers are faced with. So the choice was to move to the mobile trailer model, which would be more sustainable in terms of funding, as well as, development too, because you can go from, they're using a CCAN, which has become quite popular in building anyway, but quickly you can put together a mobile unit, you can move it on site, it's not permanently fixed to the ground, so you can just get an agreement to park it in the lot of the detention center. And this seems to be a model that could be developed and implemented quickly across various constituencies wherever. And they're thinking about doing it now. They did it in Toronto, they're thinking about doing it in Ottawa now too. And so if it starts to gain some traction, I think others will take notice of this model.
Excellent, thank you. Any other questions from the attendees?
I'll add one more thing. And this, again, I'm the sociologist that came into this whole public health research team. And not to downplay my own whatever training, but again, what struck me, I'm brought into this research team doing community health, community-based research. And what I started to see was all of this, these grant-funded projects not only do the research, but actually develop the intervention and implement it. Like, you tend to see, like, once that funding's over, that it's not renewed and the program ceases to exist. So it was promising to me to see this shift that John Howard, once they lost that more stable and robust funding for the bricks and mortar, that they were able to be nimble enough to adapt rather than let all of this good work and will in the community kind of fall.
Excellent. Danisha, any final thoughts on moving this line of work forward?
It looks like someone just came up with a question.
I've seen your protect and unlock. That a root cause.
Yeah, it's really interesting that you bring that up. And again, my paper was from the philosophical lens of Foucault and Agamben. I'm doing my own study on this. It's a qualitative, interpretive, phenomenological analysis study of both registered nurses and law enforcement officers who interact with one another. And I would say that I'm not through the data analysis yet, but what is really interesting is overwhelmingly law enforcement officers do feel that their roles with nurses are quite similar, and overwhelmingly the nurses feel quite differently. And I really think that that really just comes from this care versus custody construct. And one of the tenets of the nursing practice is to make sure your patient is free from gratuitous pain, and concepts like autonomy, freedom, seeking potentiality are core constructs from the nursing practice. Whereas in that moment, custody and control is the goal of law enforcement, and safety and preventing escape. So those two concepts are inherently in discord in that moment. But it will be interesting as I delve through the data to hear more reflection from both nurses and law enforcement on the meaning making that they have in this example.
Excellent. And we're right up on time, 2:50, and Jennifer is already sending emails and chat. Thank you so much for your work, and let's continue the good work. Thank you.